Good evening, everyone, and welcome to episode 7 of Pain Consultants USA podcast. Tonight, Dr. Bonner and I are going to talk about a common condition that usually affects people as they go through life. It's called spinal stenosis. So we see this very commonly. It's a daily issue within our practices. So how you doing tonight, Dr. Bonner?
I'm great, thank you. How are you?
Good. So maybe for our listeners and people watching on YouTube, can you maybe just start off by describing how patients that you see who have spinal stenosis may present?
Yeah, so this is definitely one of the most common problems that I see in my clinic, and generally the most common thing we hear people say is they have low back pain, a lot of times radiating into the legs, can be one leg or both legs, and can be just into the butt or all the way down the leg into the foot or any kind of combination. And we see that pain is typically worse when the patient's standing or walking, and it's typically improved when they're sitting or laying down. And I always tell patients and ask them about kind of what is the classic question we get in med school, that like an older patient has low back pain radiating into the legs, and they can only walk maybe a half a block or a block without any assistive device. But when they go to the grocery store, they can kind of lean on the grocery cart, bent over a little bit, and walk around the grocery store without any pain. And and we're going to talk more about this, I'm sure. But the problem is, of course, a narrowing of the spinal canal, and that canal gets even smaller when we stand up upright, and so the nerves get squeezed in that position, and then you get pain in the back and down the legs. And if you bend over or you sit down, the pain tends to resolve because the compression is relieved on the nerves, and so that's kind of the classic patient that we see.
Yeah, and I'm always shocked when I'm listening to patients talk, and you ask them what makes it worse, what makes it better, and they usually always kind of bring up the shopping cart.
Yeah,
They're
yeah,
at the store.
yeah. And even if they don't
It's
bring it
funny.
up, you bring it up to them, and they just, like, as soon as you start talking about the grocery store, they just start nodding their head. They like know exactly what you're gonna say, and
Yeah.
it's just so classic. It's funny how patients really like figure it out themselves. They figure out how to get around, and you hear, oh, that's how I go get my exercise. I've been doing that for a year. I go to the grocery store and I walk around. You're like, okay, well, you answered the problem, so.
Yeah, you could next time you're at the grocery store, yeah, you could check it out. You could see which patients are older, leaning on the shopping cart, just walking around slow.
Yeah, definitely.
Um, so yeah, you hit on briefly. Okay, well, what causes it, right? So all of these patients, like you said, it's exertional leg pain. So unlike what we classically think of with a disc herniation, where the pain might actually be a little better with walking, worse with sitting, these patients, it's usually the exact opposite. So pain is worse with walking, standing, gets better with sitting. So using our little model here, right? So when we talk about stenosis, we're talking primarily about the center canal, right? So in there, normally there's a nice big opening, enough room for all your nerves. That narrowing starts coming in, and it just shuts down the opening for all those nerves as they pass through. Typically happens low down in the lumbar spine. So most commonly L4-5. We'll see it at other levels as well. And the reason it usually happens in older patients is because it's kind of a constellation and a symptom of just wear and tear, right? So when we look at the disc or the model here again, right? So if we're looking, this is almost as if you were laying down on your back and we're standing at your feet looking up you. So again, your belly would be here, your back would be down here. And so within this canal, the front part right here where my finger is, there would be a disc. So as you go through life, you start getting little disc bulges that would push down into the nerves. You also get some arthritis in this area here. Arthritis, just like with the knuckle, starts to grow and it pushes in from the back. And then you also have, it's not on this model, but right where my finger would be, there's a ligament here. So just like ligaments in the knees, fingers, and wrists, those ligaments with time can get bigger and thicker, and perfect storm. Everything kind of compresses in from the front and back and causes stenosis. That's why usually elderly people are the ones we see with it.
Yeah, yeah, I would say it's extremely common in the elderly population. And I think that's pretty classic. And I don't, we don't tend to see it too much in the younger population. It's pretty difficult to find that in the younger population. Um,
Yeah, I would say some people can be born with congenitally narrow canals. So we'll see it. It's very rare.
right.
When we do see it in younger patients, it's usually a combination of like a large disc herniation in the setting of like a narrowed canal, just the way they were made.
Right. And that's a good point. Like you said, it's always like a combination of multiple things coming together to cause it. So if you happen to be born with a smaller canal, you're just more likely to get it because the degenerative changes that you get that then kind of make the canal a little bit smaller here and there are just more likely to overall decrease that area. Some people are born with such a large canal that they just have minimal chance of having really significant central canal stenosis. You see some of these people, you look at the MRI and the central canal is just gigantic. And you're like, you just got lucky, you have all these degenerative changes, but there's no chance your nerves are going to be squeezed in the central canal because your canal is just so large. So you see kind of both. You see both aspects of it there, and all people along the spectrum there.
Yeah. And I know there's a couple different thought processes behind, well, what causes the pain, right? Is it direct compression of the nerves? Is it have to do with kind of blood flow? I've seen some articles where they've looked at actually like the cerebral spinal fluid, so the fluid within the fluid within what the nerves kind of lag. Um, what are your thoughts?
Yeah, I think there's a lot of thoughts about that. I think it depends on the situation. It's probably a combination of some of those things, but it's probably different in different cases too. You got to think that when some of these patients have actual like physical neurologic deficits that evolve as they've been standing for longer periods of time or as they've been walking for longer periods of time, like someone who maybe stands for 5 minutes and gets like a weakness in their leg related to the nerve impingement. You have to think that they're developing what we would call like probably a conduction block in that nerve where the nerve is not functioning related to the compression, and then that kind of resolves as you decompress the nerve. um, you know and perhaps maybe that's why people get the pain that they get too. I think certainly the blood flow to the nerve has got to be concerning. You have to imagine that the blood flow to the nerve is not very good when the nerve is being compressed like it does in spinal stenosis. Um, and the other thing we see sometimes is we see kind of people with chronic stenosis who then have like exacerbations of really bad pain episodes that take a while to calm down. And you have to think that maybe there's some release of inflammatory material from like a nearby disc maybe that might be causing symptoms on top of their chronic condition. So we see people who have spinal stenosis, and you can see really severe stenosis on an MRI where the patient has really no complaints. And that what I see a lot is that tends to wax and wane, meaning like, the patient might be really well for 6 months and they come in all of a sudden, pain's really bad, calms down over a few months, and then they're okay again for a few months and it comes back. And, I've read some things about that where, there's some thought that maybe there's some release of inflammatory factors from disc material that might kind of irritate the nerves, cause them to flare up for a little bit, and then when that calms down, they feel quite a bit better. Or maybe they're developing like a little bit more compression, and the nerves then have to kind of get used to that space. I don't know. I don't know if we know for sure, but it's probably some combination of those things.
Yeah, I mean, I would completely agree with you, and it probably has to do a little bit too with exactly where the stenosis is most severe, right? So, on that model I highlighted, kind of right in the center, but you can also get some, right? A nerve would come out right here, like in this part of the model, this yellow little nerve here. You could get a lot of stenosis where the nerve exits the spine too, and maybe where it exits, the vascular supply might be more, more at risk of injury there or compression. You mentioned like a conduction block, right? So I always tell my patients these nerves are just like the wires in our walls, right? There's the metal within the wire, and then there's the insulation or wrapping around it. So if you have an issue with the insulation around it, that can slow down the signals, right? If you have an issue with the wire itself, that can cause its own issues too. So depending on what part of the nerve and for how long it's compressed, it can affect those things. When we see patients with this, I guess, what's your typical type of workup when you're suspecting spinal stenosis?
I mean, most commonly, a lot of times they'll come having had an MRI of their lumbar spine already, and I just really like to see those images. I think we'll always say that we want to see the images when we order a study or when a patient's had a study. But if you read a report, sometimes you might not get a great picture of what's really causing the symptoms. So I want to see the pictures and be able to correlate some stenosis to the symptoms that the patient's having. Just like you said, it might not be the whole central canal. It might be what we call the lateral recess. And if it is just one part of the canal, that's something that might not be kind of specified in the report. It might just say like, oh, moderate central canal stenosis. But you take a look at the pictures and you see that really there's some really severe stenosis in one area of the canal that might be causing the symptoms. So, I think typically if a patient comes with an MRI, I really want to see those pictures and relate it to their symptoms. I don't, if they have stenosis type symptoms, I don't tend to order an X-ray. If they come with symptoms and haven't had any treatment at all, I usually try to start with some physical therapy and a few basic medications first to kind of see if we can just make it calm down, as long as there's no neurologic deficit. If there's a neurologic deficit or like a trauma, a lot of times I will get imaging sooner rather than later. But, typically MRI is my go-to test to confirm stenosis. And if they've just come to me for the first time and it's kind of new symptoms, I would tend to start with a medication or two and some physical therapy first.
Yeah, I mean, to truly diagnose stenosis, you either need to have an MRI or a CAT scan. Yeah. I would agree. X-ray not going to really help you here. I mean, it's going to show us the arthritis, which is probably contributing to the stenosis. You can infer disc bulges if the loss of disc height, but yeah, I would completely agree with you. Just briefly going back, when you mentioned the X-ray and different things, it made me think of when you're standing too, a lot of people get some micro instability. Segments can move a little bit, and that's something that you won't pick up on the MRI or CAT scan. So the stenosis is probably a little bit worse, like you said,
Yeah,
um,
definitely.
when you're standing.
Yeah, another
So
thing, exactly. So, a lot of people like to get open MRIs now, and some of those they are maybe in like an upright position, which may be useful. But one thing we talk about is some of these tests are dynamic, meaning we can watch what happens when we move, and some of them aren't, and they're just a static image. And so when you're laying down and you get an MRI, that may show us some stenosis, but that's not the same picture if we had taken that MRI when the patient's standing up. And we need to keep that in mind sometimes, because sometimes the picture isn't really conclusive, and we need to think about, okay, well, they don't have any symptoms when they're laying down. They feel great. So maybe it looks much worse. And, there's definitely cases of that. And there's probably more in like an academic center where you can get like a dynamic MRI done, or get MRIs in multiple positions to see how the canal changes or see how the spine mechanics change. But it's definitely something for us to keep in mind, and something for a patient to keep in mind if the MRI doesn't look that bad. But if you don't have symptoms when you lay down, it's possible the MRI really doesn't look that bad when you lay down. It could look like much different if you had it in a standing position, if that's where your symptoms are.
do you routinely get EMG nerve conduction tests if you're suspecting spinal stenosis?
No, I do not. Unless there's significant neurologic deficit in the lower extremity that I'm concerned about, or if the symptoms don't really match the picture on the MRI, that's some time then I would get an EMG and nerve conduction studies. But I typically don't. I see this condition so commonly that I think it would be a lot of overkill, and I don't think it's necessary. It doesn't change the way that I treat the condition typically. Uh, yeah, I would say
Yeah, I
don't
mean,
change it. Yeah,
I you could see a normal study too
yeah,
uh, with
absolutely.
central canal stenosis. I mean,
Yeah,
you could have moderate to severe stenosis.
yeah,
Study comes back normal.
yeah,
Um, it just has to do again with where the nerves are affected. Maybe if
exactly.
it's farther lateral or where the nerve exits the spine, you might see something. But I would agree with you there. It doesn't really change the clinical context in majority of patients.
Yeah, and same thing also like with the MRI. With EMGs, it is possible to have kind of normal findings because you're in a position where the nerves aren't being compressed. That would be a bit of a rarer situation. But again, if the nerves aren't compressed when you're laying down, you get the test laying down, the test may not show, anything. If there's axonal damage, of course, we will see something, but it doesn't tend to change anything about how I treat the condition. So I tend not to order those tests.
Yeah, and this goes into a little bit of the nuts and bolts of nerve conduction tests, but like you mentioned, a conduction block, right?
Yeah,
So you to be able to diagnose a conduction block, you have to be able to like you have to shock or apply electricity above the area of the conduction block, and
right,
below it,
right,
you physically can't do that when the
right.
conduction block is back at the spine. So
Yeah, I mean, you could
so
do
just a technical.
you could do some more of the kind of more intricate tests and assume a conduction block based on, maybe an H reflex or something. But,
Yeah.
that's really getting into a very detailed EMG, and it's probably just not necessary most of the time.
Yeah.
Yeah.
Okay, so we diagnose, you know, spinal stenosis. You mentioned medications. What have you found certain medications to be more effective than others? Or what are your
Uh,
usual go-to meds?
I think I really struggle with giving patients meds for spinal stenosis. I certainly give lots of medications for this problem, but I don't find like that one that really works very well for this. I think we've talked about in other podcasts some of the different types of medications. Certainly try some of the neuropathic pain medications. If they're tolerated, sometimes patients find benefit from them, but I think that especially when I'm finding just the patient has what we call claudication, where they feel fine sitting down and they stand up and walk for a while, I don't find that a lot of these medications help that, because I don't think that they change the conduction of the nerve, and maybe they calm down the sensation from the nerve, but I don't see a lot of great effect with medications. I'll try some of the neuropathic meds like gabapentin or pregabalin. I always kind of recommend acetaminophen as something that's safe to try. I don't know that it, for any specific reason, will work well for this, but it's something that's typically safe to try. And occasionally I'll try a muscle relaxer like tizanidine, but I don't I don't know if you find anything that works really well. I don't find anything that tends to work very well for this kind of patient.
I mean, I would agree. When you're talking pure central stenosis, I don't see much that helps. When you're, if there's stenosis or we're thinking that it's more where the nerve exits the spine, I think, at least in my experience, I've had a better success with, like a gabapentin or a pregabalin if they're having a lot of leg pain and it seems like it's more where the nerve exits the spine. Not sure if that's because, the DRG is getting affected or,
Interesting.
but again, not everybody, but I've definitely noticed a trend in that regard.
Interesting. Yeah.
Um, what, okay, so, we're confident that it's spinal stenosis, but we always want to have our differential diagnosis, right? We never want to kind of misdiagnose something. What's sort of on your differential diagnosis usually when patients will come in
Yeah.
with exertional leg pain? So pain that occurs when they're walking or standing improves with rest.
Yeah, I think other thing we always talk about is the other type of claudication, which is vascular claudication. Um, and for patients, that's kind of leg pain that's related to problems with the arteries in the legs, typically the blood vessels that carry blood to your muscles and other structures in your legs. So, um, and the difference we kind of see there is, if you're having what Dr. Connor referred to exertional leg pain, meaning you're walking, your legs start hurting. With vascular claudication, if you just stop walking and remain standing, the pain should resolve because you're not exerting the muscles anymore and you're not requiring more blood flow to them. And so the pain should calm down with just stopping your walking. With neurogenic claudication related to spinal stenosis, uh, you need to either like sit down or bend over typically for the pain to go away, because if you remain in that standing position, the nerves are going to remain compressed and you're going to stay with having that pain in the nerve in the legs, excuse me. So that's the main thing I definitely think about, and I try to kind of work that out with the patient. Okay, if you walk a block and it starts to hurt, what do you do to make it go away? Do you have to stop walking, um, or do you need to sit down also? Um, with vascular claudication patients, usually they're very commonly they have a big history of smoking. So I'll just ask about smoking. If they weren't a smoker, I would say it's much less likely that they have vascular claudication. And of course, you can be a diabetic and get a lot of arterial problems in the legs, but a lot of times they're big time smokers who get those vascular problems. And then some of the other things that I see kind of referred over that are thought to be maybe spinal stenosis. Sometimes I see hip arthritis patients who have kind of pain in their thighs with walking, and I think we've talked before about how I don't see too much of the nerves in the spine being compressed that cause pain in the front of the thighs. And so if the patient complains about pain with walking that's more in the front of the thighs and in the groin maybe, I'll tend to think more about hip arthritis. And of course, with hip arthritis, you can have pain kind of in the butt and in the low back area too, but it's not usually as severe in that area as it is more in kind of the thighs and the groin. So that's something that I look for if the pain is more in the front of the thighs. What about you? Anything else you're thinking?
No, I mean, I think that was the common list. I mean, just to hit on the hip arthritis, I would agree. Front of the thighs, anytime you have arthritis in a joint, pain can be referred a little bit away from that joint. Um, you know, when we talk about like exertional leg pain and you highlight it, pain doesn't have to go all the way down the leg. So some people, when the pain kind of stays in the back or goes into like the buttock or just into the back part of the thigh a little bit, sometimes we'll think, is this like an SI joint issue? Um, we'll see that referred over sometimes too, where someone's thinking it's an SI joint issue.
Yeah.
Exam sometimes it's hard to tease out because oftentimes patients will have stenosis and they'll have arthritis in the SI joint. So I think history is definitely important.
Yeah.
Yeah,
Then the other thing we
you know,
test
I,
sometimes for patients is, and patients might find this out themselves, but riding like a bicycle is usually okay in excuse me, in spinal stenosis. But if you have vascular claudication or problems with the arteries in the legs, typically riding a bicycle will still cause you that pain in the legs because you're exerting the muscles, you're not getting enough blood flow to the muscles, and then the muscles start to kind of cramp up and hurt. But in a seated position, your spinal stenosis isn't as severe, and your legs tend not to hurt when you're exerting them. So you might have pain with walking, but no pain with riding a bicycle if you have spinal stenosis. And in vascular claudication, you should have pain with both of those because you're exerting yourself in both cases. So that's another thing I look out for in terms of the history to kind of differentiate between those.
yeah, that's a good tip. Then, we try some medication, we educate the patient, we confirm with our diagnosis, then we might get them over to therapy. Um, the challenging part I have a lot of the times is by the time we figure out what it is, patients have usually already had therapy, kind of non-specific therapy, because let's face it, the majority of the time anymore, you need to have therapy or before you can get advanced lumbar spine imaging.
Right.
So they get non-specific therapy for back pain or leg pain, which they might be thinking is a hip or like a herniated disc. Therapy doesn't help, or it makes it worse because they were doing a lot of extension-based activities when they should be doing more flexion-based.
Right.
Sometimes it's hard to convince patients to give therapy another try. But I would say, and I think we'll go into a little more detail, I think if we diagnose it correctly, I think giving therapy an appropriate try should be something that, um, it is worth your effort because the studies show, I mean, like you mentioned, there's ups and downs with stenosis, just like a lot of different lumbar spine issues. But over time, oftentimes these kind of flare-ups will calm down.
Yeah.
And majority of the patients I see, the stenosis has been there for years. And something happened that kind of set them off. I mean, I'd say more than 50% of the patients, if you really get into the history, I mean, they might have slipped and fell, or they remembered overexerting themselves out in the yard one day, and then it kind of started after that. So there's usually something that sets it off, even though the stenosis has been in there for years, kind of going back to what you mentioned as far as like an inflammatory event.
Right.
So if you're patient, which can be difficult, because with stenosis, I mean, sometimes you're stuck sitting down all the time. It really limits your function.
Yeah.
But if you could be patient and optimize maybe that directional preference with more of a flexion bias rather than an extension, which we see with herniated discs, therapy could be effective. What are your thoughts?
Yeah. I've had definitely a handful of patients who have really severe exacerbations of really severe stenosis. And, I find that they all tend to get better if you just wait long enough, Um, didn't tolerate probably non-specific therapy and didn't want to go back. And, I remember one guy particularly who I was going to try to do an epidural steroid injection, which we'll talk more about, but couldn't even find a position for him to lay down to get like flat enough so that I could take the x-ray pictures to do the injection, because if he laid flat or even really close to flat, we tried putting many pillows under his stomach to kind of curl his spine, flex his spine a little bit, but he couldn't tolerate anything close to a really straight spine or an extended spine, and couldn't do the injection. And he wasn't a surgical candidate based on his age, probably 90 years old, and um, he just waited. It took 4 to 5 to 6 months, but he spent a lot of time laying down, which is it's not great, but it just gets better. And it's not because the stenosis changed. It's just maybe the nerves can become accustomed to that smaller space and learn how to function in that smaller space. And now he walks upright. He's fine. It just took a long time. So I tend to see that these patients do get better with time. I think, like you said, that's what studies have really shown, is that if you wait long enough, the pain will calm down. There will probably be exacerbations again in the future, but each time, most people, if they wait long enough, um, it will calm down. You probably don't have to wait if you really don't want to. Those are the patients who end up getting surgery. And in rare, severe cases, you might have some weakness, loss of control of bowel and bladder, um, numbness of the genital region. Like we talked about, these are kind of really red flag signs. Those people are the ones who more need the surgery, but generally a wait and watch approach will work if the patient can just wait long enough. In the meantime, like you mentioned with therapy, I think we want to try to get more flexion based. We want to try to curl the spine forward, the opposite of what we do with the disc herniation. And, if you have a skilled therapist, they may be able to help you with ways to do that, kind of learning how to tilt your pelvis kind of posteriorly to then flex the lumbar spine and open up the canal a little bit. But like you said, if you don't get a therapist who knows exactly what's going on, you may kind of send the patient in the opposite direction with that.
Yeah, and I think it's, we see it so often that, when you kind of start to recognize patterns, and you hear the same thing over and over, and I just pick it up, or we're more kind of in tune with looking maybe for stenosis up front in the certain patient population. So as where others, you hear it, but you're not picking up on the subtle cues, and okay, well, let's treat you this way. Let's work on that extension, and then, bad experience, bad outcome. And then it kind of, yeah, it's hard to know, but it kind of sets the ball in motion to kind of dictate how your treatment's going to go years down the road, right? I mean, if you refuse any more therapy and you're frustrated, that's going to predispose you to probably making decisions about being a little more aggressive with your treatment, which could subsequently lead to a surgery.
Right.
So it's interesting. Little things can have a snowball type effect
Right,
in that
exactly.
regard.
Like if you get the best physical therapist from the start, you know, you might you might get better. And if you don't get the best physical therapist, or a physical therapist with less experience dealing with these types of issues, you might not get exactly what you need. You don't get better, and then, like you said, it kind of just snowballs down the way. Maybe you get some injections that you didn't need, and maybe you get some surgical procedure that you may not have needed if everything had kind of gone right in the beginning with the right physical therapist or something. So it can be
Yeah.
tough. It can be a tough problem to deal with too.
Yeah, I mean, I'm always a believer, like, no matter what the issue is, once the nerves in the spine are sensitized, it takes a while for them to be desensitized.
Yeah.
And if you have patience and kind of the knowledge that I hope we could at least impart a little bit, that oftentimes these things will calm down if we just limit how much we aggravate them in the short run. Again, the short run, big picture, 4 to 6 months, yeah, so seems like a long time, but compared to 10 to 20 years, you know,
Yeah.
it's very short. So if we can kind of frame it that way, oftentimes we can do pretty well with managing these symptoms.
Yeah, and it's not to say that it's like easy to tell a patient to do that. I don't like having to tell them, but um, when you're kind of at the end of the road, you've tried medications, you've tried more aggressive pain medications, you've tried injections, you've been able to do them, or you haven't even been able to do them, and they have when you've done them, they haven't helped. You know, it's the patient's like, "What's next?" And you're like, "Well, it's surgery, or it's just wait." And you just wait a while and it'll get better, and trust me, it'll get better, but you're gonna have to wait. And it tends to get better, but it's not something I like telling patients. You see them, I'll have them come back in a month and they're still miserable and they're like, when am I going to get better? And you say, just keep waiting. Just, I feel like we've said this in other podcasts, but a lot of times if you wait, a lot of these things will get better. That doesn't mean wait on everything, but if you have a good diagnosis from a good clinician and he tells you to wait and it'll get better, a lot of times that's probably true. It probably will get better. But also don't think that we want to just tell you to wait. We would love to make you feel better sooner rather than later, but sometimes it's kind of out of our hands based on, some of the treatments just don't work sometimes, and sometimes we have nothing left to offer you. So
Yeah. So let's assume they got the right diagnosis, they've received the appropriate therapy, and they're still having exertional leg pain. They've waited, 6 months, even 9 months, and it's really interfering with their ability to go to the store, go out with their significant other, play with their grandkids. So then, at this point, depending on what the MRI shows, so let's assume it's one spot in the back, the L4-5 area, which is the most common, that you have moderate to severe stenosis. Normally I'll have the conversation with them regarding potential treatment options from here. The two most common being an epidural steroid injection. And then the other is, talking with the surgeon about surgical decompression. I think most times it's pretty well accepted that, you know, without any of those red flag signs or symptoms or progressive weakness or neurologic findings, that, you try an epidural before you go for surgery. Would you agree with that?
yeah, definitely. I think it's very, very safe to try. So I'll usually try at least one, um, and then kind of assess the response and go from there. So, but I think generally it's accepted that that's probably a good approach. I think even a lot of surgeons who don't do those procedures, if you send the patient to them, they might send them back and say, hey, why don't you try this first and see if it works or see if it offers any benefit. So, yeah.
Yeah. I always tell my patients, if we can't improve your quality of life and function with 1 to 2 injections, I don't plan to do anymore. I think years ago, the epidurals probably got a bad rap when you would hear about these series of 3.
Yeah.
So every 2 or 3 weeks, you'd get another injection.
Yeah.
I think studies came out that kind of say, well, that's not necessarily needed. So, we'll do one. I usually will see the patient back 2 to 3 weeks later, kind of assess where they're at, depending on how they responded to the first one. If it helped but only temporary, or helped partially but not enough, we'll do another one pretty quick. And is that kind of your algorithm as well, or?
Yeah, I'll do one and then, always, like I've talked about, I always try to assess the response right after. Do they get some immediate relief? And then see how long that lasts. If it gives some, and I usually see patients about a 2 week follow up from the injection. So if they're still feeling somewhat improved, I may do a second one to see if we can add on to the top of that. If they're 90 to 100% improved, I say, okay, let's see how long it lasts for and go from there. If they got very temporary relief, my approach is sometimes I'll offer maybe doing a different type of steroid. May just try like a different one to see if it has a different effect for them. I don't think there's any kind of great research to support that approach, but if it's a safe procedure typically, and it may be worth it to them to give it a shot, especially if they like aren't a surgical candidate, they don't have many other options.
Yeah. So, I mean, I would, just, and I know we've talked about this before, but with the epidurals, I mean, there's two ways to do it,
Yeah.
right? So, again, with the model for those of you looking on YouTube, so this is a side view. So your back is here, belly would be over here, where the yellow nerve is coming out here. You can do what's called a transforaminal approach. So you could come in with a little needle over top of the nerve or sometimes underneath in special circumstances and put the steroid medicine in and get that medicine to kind of flow into the canal. So that's a transforaminal approach. I believe it's the most common type of epidural that's done nowadays. It's kind of, I guess you would say, it's the newer approach. When you do an injection in the transforaminal plane, you typically use a certain type of steroid called dexamethasone. The other option for stenosis would be to do, I was call the old school approach, which would be the interlaminar. So again, these bones here on the backside are your lamina. So again, your back is here. You would actually come in straight from the back, just like a labor epidural. And usually, if you do have really bad stenosis, you have to come at least one level down. But then you can make the argument to use a different type of steroid, maybe like depomedrol or betamethasone or Kenalog. So that, you probably shouldn't use in the transforaminal approach anymore. But at least in my clinical experience, when the stenosis is in the center of the canal, seems like the interlaminar epidurals might work a little better.
Yeah.
What are your thoughts?
Yeah, I think we've talked about how maybe there's a study that that showed a little bit better improvement in the interlaminar approach as opposed to the transforaminal approach for patients with central canal stenosis. I tend to go towards the transforaminal approach just because I practice more of those. Basically, I did more of those in my training, and so I tend to do that, and I'll try to kind of ensure that I get good flow of the medication when I inject contrast towards the area of stenosis. And then I think sometimes if that didn't work or offer temporary relief, another approach is to just try the different approach and see if that works too. Try the interlaminar, see if that helps, and then really, go from there. If it doesn't help, if neither of them helped, we can talk about what the other options are. But that's definitely an option to give them both approaches and see if either one helps really.
Yeah, and that's what I'll typically do. Usually, I would start with a transforaminal. You're putting a highly concentrated anesthetic dose at that specific level. Sometimes, like you mentioned, you can use that for diagnostic reasons as well. But if one transforaminal doesn't really work, I'll usually go over to a interlaminar epidural, or in some cases where that nerve exits the spine, right? Instead of that opening, it's just clamped down completely. Usually transfer aminals are pretty uncomfortable for patients
Yeah.
in that situation. So I'll come from the back, do an interlaminar, but instead of being in the center, if you can see that, I'll be off to the side where uh, the nerve's being pinched. And it's just more easily tolerated by the patient. And you're likely getting more of the medication to that place because the stenosis isn't interfering with things.
Right, right. And for patients, a lot of that, there's not there's not great evidence to kind of say, oh, like doing the interlaminar or moving the interlaminar a little bit to the side really kind of changes the outcome. Changing the steroid, we don't have anything to show that that changes the outcome. These are just things that some of us have learned, and some people try to see if we can get a patient relief. And a lot of times we get asked like, oh, well, how long is this going to help for? And the honest answer is, I don't know. If someone tells you it's going to last for 6 months, you know that's probably not true. The best we hope for is probably like a couple months, and that's like 60% relief for 2/3 of patients maybe. So but so just be wary of someone telling you it's definitely going to get you better, because a lot of times we don't know if it's going to help, but it's certainly worth trying. It's safe if done correctly and done with the correct procedure and the correct medication, like Dr. Connor was discussing before.
Yeah, and I always have that open conversation with the patients. Hey, listen, when you look at the data out there for epidurals, their epidurals are done for a whole bunch of different reasons. When it's a big disc herniation touching a nerve, work pretty darn well. When we're starting to talk about just pure stenosis from arthritis, bone hitting the nerves, it's more 50-50. It really is. But again, risk benefit. I mean, when done appropriately, very, very, very little risk. To the upside would be quality of life and functions improved. So, I have that honest conversation with the patient up front, and usually we'll try to do one or two to see if we can help. I always frame it when they do ask, well, how long should this work? I say I define a success by 3 to 4 months of relief. So not saying that's how long it's going to last, but if it lasts that long, well, that's a success for that injection. I really wouldn't expect it to last much longer.
Right.
So if it takes away 100% of your pain, but it's only for 6 or 8 weeks, I mean, that's not something that's sustainable,
Yeah.
So that would not be a success in my opinion.
Yeah. Okay.
Okay, so we talked about the epidurals. Before we get into the surgery, we'll just kind of highlight two newer type of interventions that are minimally invasive that could be done for stenosis. So the first has to do with where I was mentioning before with our little model again, if you could see it here on our video. It's not on this model, but right where my finger is, there would be ligament that grows, and the ligament pushes in, right? So on MRI, a ligament looks black, and then instead of being very thin, it gets really wide. When that pushes in like that, there's a new procedure it was around, then it was off the market because insurance required more research. They did the research. They showed that there's a benefit with improved standing duration and ambulation and how far they could walk before the symptoms came on. I think the main study was out of Cleveland Clinic. The studies, I believe, are called the Midas trials, so that if you wanted to look those up. But so the goal with this procedure, again, under X-ray, they're larger size needles. It's more of like a little portal that goes in. There's not really a big incision. There's no, sutures or staples afterwards. But the goal of it is to actually remove some of that ligament. And again, done under X-ray. The safety, it's been shown to be as safe as an epidural. In my experience, that this procedure seems to work pretty darn well for people with like 1 level stenosis. Like, so when you pull up that MRI and you say, oh my God, that's the issue right there. And the ligament's huge. There's arthritis, but it's not so much the bone touching or crowding in on the canal. That's when that procedure works pretty darn well.
Yeah.
It's a little more involved. I would still recommend, I think the typical treatment would be steroid injection via an epidural, as long as they're not like a brittle diabetic, before something like that. Um, Other limitations with that right now is it's primarily only approved for Medicare population and some of the Medicare Advantage programs. So commercial insurance, not yet. It will probably be in the not so distant future. And then the second procedure is where now you can actually put a little device between the spinous process. And the thought process, or the thought behind that is, if you put a little device there, when you stand up, you can't kind of arch back all the way. You're kind of tilted forward a little bit, just to kind of prevent that segment from extending and pinching down more on those nerves, like Dr. Bonner described before.
Yeah, exactly. Again, when you stand up, the spine, what we call extends, it kind of arches backwards. When you do that reliably in the lumbar spine, almost everybody has a narrowing of their central canal, and the nerves get compressed, and then you get the pain in your back and your legs. So if you can block that at the level where if you can block that extension at the level where the compression is happening, perhaps you can block the compression of the nerves. And I don't perform either of those procedures. I've heard, I think you said that you get some pretty good results with the decompression procedure. I know I've had a couple patients that have had the procedure you just described with the device between the spinous processes. One lady I know in particular, she had kind of temporary results. It helped for a year or two, and then her stenosis actually just got worse, and she ended up having surgery, which actually worked really well for her. And then the other person had it, for years. I don't see them anymore, but they were doing fine as far as I know. So, it's just another option for certain patients with specific types of stenosis, and something to ask your doctor about if you're having this problem and you have spinal stenosis.
Yep. And again, not all providers do it, but most will know about them. So it's always something that if you wanted to learn more about, you could go talk with, have them just set you up with someone that does them, just to get more information. It never hurts to learn more about what's out there. Especially with the decompression procedure, reviewing the MRI is very important. Like you never want to go off of a radiologist read, because they very rarely measure the actual thickness of the ligament and put that in their report. So you want to go to someone that has done these and was trained appropriately.
Yeah.
So getting into really the last form of treatment, which is surgery, right? I mean, I think we all know tons of patients who have had surgery after the appropriate conservative care and who have done really well. I mean, surgery for this, can be very beneficial, again, when done in the appropriate patient, when reviewing the MRI by the surgeon is done, and, with the knowledge that not all spinal stenosis is the same. I tell my patients, again, I don't perform the surgery, but before I have them go see a surgeon, I always frame it with regards to function, right? If what we've done hasn't improved your function, well, you know what? Maybe we should have you talk with a surgeon.
Yeah.
And I'm not sure what numbers you might quote, but in the literature, somewhere between, it depends, 15 to 25% maybe failure rate to a surgery like that. I
kind of leave that up to the surgeons to say, but I'm with you on the function thing. It's just so important. I saw like a 90 or 85-year-old lady the other day who has been wheelchair bound for years, and her family members were talking about how they want to stand her up and have her walk a little bit, but she's been in a wheelchair for years already and doesn't really do anything, just sits and watches TV all day. So it's like, in that kind of case, is it really worth kind of getting more aggressive with things? Probably not. It's really, you got to nail down the details and have long discussions. But it's such a good point that is the function is so important. If you're someone who's more active, I've had patients who are typically the patients I send for surgery for this are very active people. They like to go out and walk. They like to go out and do lots of things, and it's really limiting that ability for them. And so, where the injection might help temporarily, the medications might help temporarily, in the end, if they keep coming back and just saying that, look, I'm still having the problem, that's the kind of person who I end up kind of referring for surgery. And even then, some people still don't get it, but it can be a very, these surgeries can be very useful. I think a lot of these cases are very clear cut where the problem is in the spine. The surgeon can decompress it very, very confidently, and the patient gets a great result from them. And that's what I tend to see really good results when patients do end up having surgery for this condition. But I think,
Yeah.
like we've described, a lot of people can get much better without a surgery. So always
Yeah.
kind of go through some conservative care first if you can.
Yeah, and just to kind of show you on the model as far as, well, what type of surgery is done, there's usually a couple variations of the same thing. So again, back is here. So if I turn and we're looking straight at your back, so my finger are where your muscles would be. You remove the muscles of the back, you see the bones here, and then you see the what we call that lamina again. So that's the landmark that we would go between for an injection. With what surgeons would do is called a laminectomy. They would actually go in and cut this bone and just take it off. I tell patients almost like taking the roof off the house, right? So it's a laminectomy, and then when that bone's removed, even if everything's pushing this way, then there's tons of room in the backside. So that's the most common procedure done. Now, again, this is why it's important to talk with your surgeon, talk to somebody, review your MRIs with them, because patients who have stenosis in the center of the spine also usually will have some stenosis where the nerve exits. So sometimes they'll have to go in and do what's called a little foraminotomy, where they'll almost like a rotor-rooter job where the nerve comes out. They might even have to remove a little bit of the joint. That's called the facetectomy. So the facet joint, they take a little bit of that away. So that's important to kind of have a conversation. Say, hey, doc, on my report, or, I talked with the doctor, they said I have bad stenosis in the center, but also where the nerves exit the spine. What's done for that, right? Because the patients who we'll see come back and still have the pain, it seems like, in my experience and opinion, that a lot of the times it's because of where the nerve exits the spine, it's just technically challenging. I mean, surgeons can't remove all the bone, or then they got to put in hardware, and they still can't remove all the bone because the hardware has to go through bone. So they are limited with kind of what they can do sometimes. But again, these are things you want to know up front, rather than being pissed off 6 months later because you're still having severe pain, or 1 year later wishing you never did the surgery. If you're going to go for surgery, I always tell patients, you want to make sure you've done everything else, and whatever the consequences of that surgery, you want to look back and say, hey, listen, I had no other option. So
yeah,
it's kind of my spiel.
Yeah, that's a great point. I agree. You got to go through everything else and try everything else, and surgery should be your last option, as long as it's not an urgent or emergent procedure.
Yeah, so I think that was a good review of spinal stenosis. I think probably in future podcasts we might get into kind of the nuts and bolts a little bit more about specific topics within this conversation. But I think that was pretty thorough. Anything else to add?
I think one thing we had maybe discussed mentioning was just another strategy for patients who are dealing with this in regards to the therapy is something that Dr. Stuart McGill calls a park bench decompression. So, like we talked about, when you're walking, if you have pain and you sit down to feel better, or you bend over to feel better, there's another way to do that to kind of decompress your spine. And that's you could Google park bench decompression Stuart McGill, and you'll probably find a video. But basically, if you find like a bench somewhere, you kind of put your arms on the bench and you kind of support all your weight with your arms, and then you let your legs hang down. It's a way of kind of performing what we would call like traction, or you're using gravity to perform traction on your spine. And by allowing your legs to hang down, you're then allowing the spine to kind of decompress at that level a little bit, which can help relieve the symptoms, and then you can go on your way walking again until the symptoms come back on. So that was just something else that may be useful for patients who are dealing with this problem, to help you walk longer distances.
And that's interesting because you're not really flexing the spine
Right.
with that.
But I think
It's
part of the
more,
problem is gravity when you're upright, right? So you get up, you
yeah,
stand upright, gravity pulls your spine down, and then what happens? Well, the ligamentum flavum that you talked about before, it buckles more than it is when you're laying down and gravity's not pulling down. Maybe the disc gets a little more compressed and the disc sticks out into the canal a little bit more. So that just shows the importance of kind of gravity pulling down, compressing some of those structures, which are then kind of converging on the center of the canal and compressing the nerves at the same time. And so by kind of allowing your spine to decompress through the also the use of gravity, but kind of hanging your legs down, you're allowing the central canal to decompress a little bit and take pressure off those nerves.
yeah, that's a great point.
Yeah.
And that's a great tip too. If you can't sit down or you don't feel like bending over, it's just another way to get you some relief to keep you functional.
Yeah, I always like show patients kind of like a bent over position with their like hands on their thighs, and everyone just kind of laughs at me because like who's gonna stand like that in public? But look, you got to do what you got to do to feel better. And this is
It's
also
true.
you get a lot of these patients who come in and their family members have been telling them, stand up straight, stand up straight. And I tell them, I'm like,
Yeah.
just let them bend over. It's fine. They feel much better bent over. Let them use their walker and just lean on it, and they're going to feel much better, and they're going to be complaining less to you about how much pain they have. So, if that canal's not getting decompressed, just let them bend over and stop telling them to stand up straight. And everyone's telling me to stand up straight. Well, guess what? I'm going to tell you, you don't need to stand up straight. If we can
It's
eventually get you to that, great. But right now, you don't need to do that.
it's usually my couples that are married for 50 plus years,
Right.
the wife yelling at the husband.
Exactly. Yeah.
So it's always
Something to
great.
look forward to.
Yeah, hopefully.
Yeah.
Um, well, I think this was a great talk tonight. It's a very common topic. Even if our listeners or viewers, don't have this themselves, I'm sure they know a family member or a friend that do. So, yeah, hopefully they're able to get something out of it. Look forward to our talk, hopefully upcoming about, we talked about doing a talk on post-procedure pain after lumbar spine surgery. So I think that's going to be our next podcast.
Yeah. All right.
Okay, buddy.
Have a great night.
Have a good evening.
You too.